If you've just joined and you have any questions, please use the chat line. You are all on mute just because we have a number of people here today. And putting you off mute could be distracting, but please feel free to use that chat line. So just a little bit about myself and my co-presenter, Marge, is also here. My name's Amanda Wood. I'm a specialist behaviour support practitioner and have been a behaviour support practitioner for well over 27 years now. So was providing behaviour support in what I refer to now as the old system, and feel that old that I can now say last century, to be honest, but it's what I've always done. I'm also a registered psychologist, but I just love behaviour support, and I learn so much every day from the people that I work with. I'm also the general manager and founder at Real Therapy Solutions. And I'm still doing a little bit of behaviour support and a little bit of psychology along the way, because I just can't let go of it. But that's my background. Marge is also with us today, and Marge is our clinic manager in our Penrith site at Real Therapy Solutions. Before starting with us this year, Marge has had numerous roles in disability leadership roles for over the last 25 years in both government, non-government, and has worked for the agency as well. So comes to us with a wealth of knowledge around understandings around plans and how they're developed and the funding within those, as well as allied health in the model of NDIS. So Marge is online and is able to answer any questions that you have that are more aligned with her level of expertise. And I'm happy to talk about any that align with mine as well. So let's have a look. There's a lot of terms used for behaviour support. The correct term is positive behaviour support. So positive behaviour support is a really well-researched, effective model for supporting people with behaviours of concern and improving their quality of life. So it has been around since around the 1950s. The research was starting on positive behaviour support and the theories and strategies that we use within that model. So it's very well researched. It very much started in the schools with children with disabilities, and has grown from there. It is not new with the NDIS. It has always been around. And it's really about looking at the function, why someone uses the behaviour they use, what do they get out of it? And is there a more, I'm going to use the term appropriate, but is there another alternative that we can support them to develop so they no longer need to use those behaviours to get what they need? And that's really at the core of positive behaviour support, alongside building quality of life, which is really what the outcome should be in positive behaviour support. So we know that it works. There is a lot of research. It's very what we call evidence-based, which means we've done a lot of research over the years, and there's still a lot of research coming out of Melbourne with a team of people in Flinders University and a little bit of Monash doing a lot of more work now around PBS in Australia. It is a clinical process, but it's not the same as a clinical process in psychology, and I'm going to talk a little bit about that. But I think the key to understand here is positive behaviour support has been around a long time. It is well researched, and it has very structured strategies and processes that we know work in getting positive outcomes. So it was around long before the National Disability Insurance Scheme. It's not something that has come about because of NDIS. It is something that many of us were working in as behaviour support practitioners long before the new model of funding arose. What has changed a little bit with the NDIS is behaviour support is a lot more heavily regulated by the NDIS Quality and Safeguards Commission. That's a really important thing that we advocated for in the changeover of the system, because there are people that have behaviours of concern, and some of the strategies that have been used historically and going back decades really breached the rights of people with disabilities. And I won't go into this too much, but there was a lot of, there was Royal Commission reports into this, where what we recognised is There are some people with disabilities who engage in behaviours of concern may be vulnerable to having their rights breached unnecessarily. And that sort of fits in with the regulated restricted practice and prohibited practices areas. So we needed somebody to be able to oversee that as we moved into the NDIS world. Previously, the governments oversaw that at a state level. They recruited the behaviour practitioners, or at least funded the people that recruited the behaviour practitioners, and had quite a large oversight over that. So now the Commission does that. So what you really need to understand there is anyone providing behaviour support or implementing behaviour support is quite heavily regulated by the Commission. And there are now federal laws in place that weren't in place before that now say exactly how this process needs to roll out and how behaviour support needs to be provided. So what is quality behaviour support? And I'm going to go into this in a little bit more detail. Good behaviour support in the NDIS is based off that theory that I talked about earlier, all of that research, those decades of what we know works. And this has now been developed into federal legislation. For anyone who's interested and wants a bit of light reading over the weekend, the Behaviour Support Rules of 2018 really outline how that process needs to be developed. And it's quality behaviour support as a theory, as an evidence-based clinical process. And then on top of that, we have NDIS behaviour support, which is the legislation around restricted practices. There is a lot of overlap, which this diagram is showing here, that what we know works is also built into the legislation, but there's also a little bit outside of that that dictates things like what the reports need to look like. That is not necessary. It comes from what we know works, but it's really dictated to us by the Commission based off what works and what we know we need to do. The clinical process of behaviour support is actually quite a lengthy one. If I drew this up for psychology, it is not as nearly as lengthy and not as intensive. And there's a couple of reasons for that. One of them being that I love behaviour support. I love providing behaviour support more than I love providing psychology, because behaviour support is so holistic. I feel like I get to know and understand the person and who they are. I find it a lot more encompassing of everything about the person than I do psychology. That's not to say that psychology is very narrow, but I just find behaviour support more understanding of the whole person. But the process is quite lengthy. And to develop good quality behaviour support, there is a strong assessment that takes place. That is with the person. There is the development of a written plan, and I'll go into that in a little bit more detail in how that's so different from psychology. There's a lot of working with the person and their carers in behaviour support and monitoring what we're implementing. One of the biggest things I find in the new world of NDIS and behaviour support is there's such a focus on writing the report and the plan because it's so heavily regulated with massive fines if it's not done. But the implementation stage, it's almost like there's a lack of funding for some participants at this stage because of the lack of understanding of how long a report can take. But also, I think for some people, there's also a level of exhaustion when the report comes out, because there's a feeling like what has happened up until this point. And I think, you know, providers need to educate, and the NDIA need to educate people a little bit more about why that happens and how we can tweak that to meet the person's needs. But the implementation part of the plan, this part down here, is so important. This is the part that I tell people it's where the magic happens. This is where we're testing and trialing and working with the person to get strategies that actually start to bring about positive outcomes. And then we're always monitoring it, and then it's reviewed, and the plan actually has to be rewritten every 12 months, which is also part of the legislation, and it's also part of best practice. We did that long before the Commission were in place as well. So you don't need to understand the process per se, but just understand there are many components of it that involve plan writing, assessment, working with the person and working with the carers and stakeholders that work with the person as well. So what's the difference between positive behaviour support and psychology? I think this is the million-dollar question almost, particularly at the moment. Positive behaviour support is not psychology. And, you know, there are some parts that overlap to some degree because the theory behind both models is similar at times. Not all the time, but at times. But really what the positive behaviour support practitioner and what the psychologist are doing are quite different. It's just that they're drawing from the same models of understanding. So also psychology in an NDIS space is different to psychology in a non-NDIS space. And this is why we're hearing a lot of talk about psychology is funded under mental health, because it absolutely is. The psychology that's funded under the NDIS is not the same as the psychology that's funded under mental health. However, again, the theories are the same. It's just the actual work or the focus that the person is doing will have the psychologist is doing will be a little different. So psychology at its core focuses on, in the NDIS space, focuses on thoughts that a person has and how their thoughts relate to their or drive their feelings and how their feelings relate to and drive their behaviours. So a psychologist will talk very much to someone about what are they thinking, how are they feeling, and how that impacts their behaviour and how that becomes a cycle. In psychology, we call it cognitive behaviour therapy. And the psychologist will work with the person on understanding and awareness of their emotions as they relate to physiological, how they feel, but also as they relate to what they're thinking and how they're behaving. And in the NDIS space, the psychologist is looking at functional capacity building. So understanding how my thoughts and my feelings affect my behaviour and looking at what skills I need to build my independence and capacity. So for example, as a psychologist, I may see someone who is NDIS funded who has I see an autistic person who is having difficulty making friends or interacting with other people, very common for some people on the spectrum. And I'm talking to them about what are they thinking when they see someone they'd like to be a friend with, how does that make them feel? And then I'm looking at, you know, what they could do to try to make friends and encourage them to learn strategies that may work. I may even work with a speech pathologist around some social skills with that as well. But I would work with someone around their feelings, their emotions, their thoughts, and their behaviours in developing that skill to learn how to make friends, interact with other people. A psychologist in the non-NDIS space would be talking about things like anxiety, depression, and working in a similar model on those kinds of disorders and difficulties as well. So those are the two differences for psychology, I guess, in the NDIS space. The other thing is psychology is usually sessional. And most of the time we provide psychology direct to the person. If the person is a child, we may involve the parent in the sessions as well. However, it would not be common practice for a psychologist to work as much with carers as a positive behaviour practitioner will. Psychology rarely requires long written reports in the NDIS space other than the report to NDIA. We would usually not focus on mental health directly, although we may be focusing on symptoms of mental health that are related to functional capacity and disability. I won't go into that too much, but there is a slight difference. So if you're psychology funded, or if you want to see someone on a sessional basis every fortnight to work on things like feelings, emotions, thoughts, and my behaviours, you're wanting psychology funding. If you're wanting to, and I'll go into PBS and what you'll be looking at there, but this is what psychology is. The other one I hear a lot used instead of positive behaviour support is behaviour therapy. And I think that's a very layman term for behaviour support, but recognising it's actually a technical term in psychology as a model of providing psychological support. So, and we often put cognitive in front of it. So there's cognitive behaviour therapy as a model that we will use as a psychologist, and there's behaviour therapy, which is part of that model that we will use as a psychologist. It's not positive behaviour support again. So the easy way to think of this is behaviour therapy is psychology. Positive behaviour support is not. Behaviour therapy, again, focuses on thoughts, feelings, and behaviours. It just doesn't focus on the thoughts as much. Is probably the easiest way to put it, but it is about understanding feelings and understanding how feelings relate to behaviours, which they do for all of us. Often how we feel impacts how we behave, and it's about educating a person, helping them understand that link, and then helping them recognise their emotions and identify other strategies. That is psychology. That is behaviour therapy. So what is positive behaviour support? So positive behaviour support is an assessment. It starts with an assessment that looks specifically at the behaviour and what's happening around it. So we don't necessarily go straight to the cognitive, the thoughts of the person. We look at what is the behaviour and what is its function? What is the person using the behaviour to try to communicate? So it focuses on specifically outlining what the behaviour is, when it occurs, how frequently or often it occurs, does it have different intensities, what happens before it, what environment does it occur in, and what happens after it. And that gives us a really good picture of specifically when that behaviour is used by that person. Then we will also look at who is this person? What are their aspirations? What do they like? What are their goals? What do they enjoy doing? Where are the gaps in their life? So often we're looking in positive behaviour support at functions, to put it very simplistically, and it isn't always this simplistic. In fact, it really is. Someone might use a behaviour to communicate, I'm in pain. So you and I would say to someone often, my head hurts. Now, if you can't say that because you have communication difficulties, or for whatever reason you don't feel comfortable to say that, or you've said it in the past and it doesn't work, people haven't responded to you, you might start to use another behaviour, and it could be a variety of behaviours to communicate you're in pain. The positive behaviour practitioner would identify the function of this behaviour. Let's say it's hitting my head. The function of this behaviour when I hit my head is to communicate I'm in pain. So as the behaviour practitioner, I would then identify, once I've established that's the function, I would then identify what is another way we can support this person to communicate I'm in pain that doesn't involve them hitting their head. And it could be a variety, again, of other tools or strategies. We would work with the person and their carers to identify that. We would most likely need the carers in the environment and the person as much as we can to understand what this new strategy is, and when they use the new strategy, reinforce it. So positive behaviour focuses on changing the environment to reduce a person's behaviour sometimes. So it's, as opposed to psychology where we're working directly with the person and teaching them awareness, positive behaviour support often looks at the environment and makes what we call environmental manipulations, remembering that often the carers are part of the environment, to reduce that person's need to use challenging behaviour or behaviours of concern. It's about teaching others how to respond to the behaviour so that the person doesn't need to use it anymore or gets what they need out of it in the short term while we teach them new strategies. It's about teaching them skills that directly relate to why they're using that behaviour. So that's why you will see your behaviour support practitioner come in and do quite a detailed assessment of the specific behaviour and what's happening around it, as well as the person, their lifestyle, who they are. Then they will go away and identify all of these, this function for this behaviour, this function for this behaviour, and look at, if that's the function, what strategies can we put in place in the environment? What can we teach this person so they don't need to use this behaviour anymore? How am I going to work with the person and everyone in their environment and their environments? And how am I going to monitor what we're doing and see if it's working? And with the ultimate outcome focused on building quality of life. Because when you build someone's quality of life, it usually means you reduce any behaviours of concern. So positive behaviour support will involve a behavioural assessment and a written report. So when you're accessing positive behaviour support, you're usually accessing positive behaviour support because you have some behaviours of concern. They're usually a safety risk or a risk of harm. And we need to understand why these are occurring. And we're going to work with everyone in the environment and the person to develop skills so they no longer need to use them in the future. Again, that's a very simplistic outline. It's not always that easy. And to be really honest with you, it can take an extensive period of time to develop those skills, particularly in someone who's been using those behaviours to get what they need for a longer period of time. But it can be very, very effective. So when we're looking at positive behaviour support, we're looking at working with the person and the carers across multiple environments. So your behaviour practitioner will come into home, any work placements, any schools if it's a child, and we'll look at the behaviour in each of those environments and work with the support networks in each of those environments. A psychologist will usually only work with the person, maybe the parents. They will often consult with other people that are important to the person, but they don't tend to work as closely with them as the positive behaviour practitioner will. Positive behaviour support looks at why the behaviour occurs and then identifies gaps in the person's life that cause those behaviours, whereas psychology will work with the person to understand their behaviours, their emotions, and change how they respond to that. The positive behaviour support will write a written report that outlines the function of the behaviour, the strategies to be implemented. And it is quite a lengthy report. That report is dictated under NDIS, if they're NDIS funded, in exactly what it has to be, and the length, pretty much the length of it, because they're dictating what's in it. The psychologist obviously keeps case notes, as does the behaviour practitioner, but there's no requirement there apart from to report back to the NDIA with that report when the NDIS plan is due for review. There's limited documentation that's required outside of case notes and maybe some resource development. That's a massive difference that I think people don't, we don't educate people well enough in understanding what that means and how useful that report is, particularly the strategies. And I think that's the practitioner that needs to educate people around that and help them to understand why we do the reports that we do. The positive behaviour practitioner will trial strategies with the person, with their stakeholders, their support network, and trial strategies. And if they're not working, they should be changing them along the way. It is a little bit of trial and error of what works for individual people. The psychologist does similar, but they only work with the person usually, or maybe the parents, to trial interventions in that fortnightly sessional model. This was one of the things when I provided both behaviour support and psychology long before the NDIS is often I would be providing psychology support to someone who had good communication skills, verbal communication skills, and could understand the link between their emotions and behaviours, because at the core of psychology is teaching someone my thoughts affect my emotions, affect my behaviours. That was a lot of what I was doing as a psychologist, supporting people with disabilities. And I mean, that's again a simplistic version of it, but essentially that's what I was doing. So if I'm providing psychology to someone, I need to be able to communicate really well with them. Whether I use adaptive communication techniques or verbal communication, I do need to be able to communicate well with them to teach them these new skills, to teach them an understanding of emotions. I can bring emotions to a more concrete level than happy, sad, angry, excited by using a variety of tools as a psychologist, because the concepts of sad, happy, angry are quite abstract. But I can bring them down to a more concrete level to support a person with a disability. But I do need to be able to have that ongoing communication. Whereas in positive behaviour support, I can support someone with a varied communication difficulties and varied, I guess, cognitive difficulties as well, because I'm working so much with the environment and their support network. I'm still getting to know the person, but I can do that in a variety of ways. Whereas when I'm teaching them about emotions and behaviours, that communication is very different to what I can do to build rapport and get to know someone and what they like and what they dislike. So often I would use the behaviour support model when somebody couldn't, I guess, fit in with what is the traditional psychology model, and if they had behaviours of concern. So those are the differences between PBS and psychology. And I don't think it's spelt out very well. I don't think we will often see plans that have been developed where the planner doesn't know the difference. And I understand, because it's actually quite complicated at times, but the way we work in both models is very different, even though the theories are very similar. Let's have a look at quality providers. There is a lot of regulation on behaviour support providers, and my opinion is there should be. It is quite a complicated area that we are working towards getting some really clear foundational guidelines on training in the field, and understanding the various clinical components of it. I think most people understand that anyone who's providing behaviour support has to be a registered NDIS provider. That's a given. It's not an area that you can pull from the Improved Relationships funding, provide positive behaviour support without being registered. And look, the main reason for this is the psychology and speech and OT are overseen by the peak bodies that sit above those, and the Australian Health Practitioner Regulation Association. Behaviour support doesn't have that to the same degree, and it's certainly something that I know is being worked on in Australia at the moment, but it's just not there to the same degree that occupational therapy, speech pathology, dietitians, psychologists are overseen by their already established peak bodies that have been around for a long time. But the other reason that the providers need to be registered is the regulated restrictive practices area, which is this area that we might be using strategies that at their very, very extreme are a breach of rights, but at the other end are necessary for safety. And it's understanding the difference between those, and understanding that when we are using one of these regulated restrictive practices, which can be as simple as a medication prescribed by a registered practitioner that is not considered, that is prescribed for behaviour management, that's considered a regulated restrictive practice, right through to things like physical restraint and time out in a room alone, seclusion. So it's quite varied what is a restrictive practice, but they're very clear on what they are. And they need good clinical support. And it's the practitioner's responsibility to provide that good clinical support when someone is using one of those strategies. So the practitioner is not saying these regulated restrictive practices shouldn't be used. Sometimes the Commission tell us we do need to say that for a lot of reasons, but what we're saying is these are being used. Let us support you so that long term, we don't need to use these. And it's the practitioner's responsibility to do that. And the Quality and Safeguard Commissioner are overseeing that to make sure we don't go back to where we were in the 1950s and 1960s and 70s, where many people with disabilities were being exploited, and there were numerous strategies being used that were a breach of rights. The practitioners need to receive regular and consistent clinical supervision, no matter their level of experience. With 30 years in behaviour support as a specialist behaviour support practitioner and a registered psychologist, I still receive supervision. It's very, very important for any practitioner to receive that. So that's something that you should be looking for, that your practitioner has a supervisor, and in many cases, their supervisor has a supervisor as well. There needs to be strong quality assurance processes. Someone checks the work being done by the practitioners to make sure that it aligns with all of these quality requirements and regulations. I think the other big thing that I will say in behaviour support is that we bill for what is done and don't bill for things they don't do. So if a report takes 10 hours, your practitioner should be able to justify that, and it should have taken 10 hours. If they're using a baseline from a previous report and it takes them 4 hours to write it because they already have a report for this participant and they're just building on that, then you would build the 4 hours, not the previous 10 hours that it originally took to do it. And that's certainly something that I encourage people to ask questions about if you're concerned about the billing that's happening in behaviour support. What should you get from your behaviour support? You should get a practitioner that works to building rapport with the person and also with their carers and support network. So that could be the support workers, the parents, teachers, therapists. Your practitioner should be very holistic and work with the other people around the person as well as the person. Again, different from psychology. And again, often why behaviour support is more intensive, more holistic, but also often requires more funding. You should be able to reach out and ask questions about your support, how they work, what they're doing, and what they're claiming for. I think that's a really big one because behaviour support has so many processes and complexities that we need to follow. First of all, your practitioner should be explaining that to you in a way that you're able to understand that, but also feel free to ask those questions. You should always be consulted. There was a horrific research that came out recently out of the Commission talking about something like 40% of behaviour support plans had been written without even meeting the person. And that is so far from best practice that it's not funny. And so you should be consulted. The practitioner should meet with you numerous times. The difficulty is if there is not enough funding to do that and the legal requirements, but that should be a discussion your practitioner has with you as soon as they realise that, which should be somewhere around the initial assessment in most cases. Clear goals around what the practitioner is working on, looking at how we're measured on outcomes and the practitioner working with you to achieve positive outcomes, and are those happening? And if not, what do we need to change along the way? And improve quality of life, which is at the core of behaviour support. Is improving someone's quality of life. I think some of this is very similar, but ensure your practitioner meets with you and other people as a positive behaviour practitioner. Ask as many questions as you want. I always encourage people to ask questions. They should be going to different environments. So if you have a work placement and they should be going to your home with you and the work placement, unless the participant is particularly outlining that they don't want that or they don't consent to that, because of the holistic nature of behaviour support. They should be giving you updates while they're writing the report. I very much understand that while they're writing the report, and reports can take anywhere from 5 hours to 50 hours, to be really honest, depending on the behaviours of concern, the number of restrictive practices, the number of functions, the number of escalations that the behaviour goes through before it gets to a peak. There are so many factors in there of what we have to document. I would say the 50 is not as regular as, say, somewhere around 20 hours to write a behaviour plan. But ask what's happening and ask for regular updates. Where are they up to? Who's been consulted? Where are they up to? That should come to you without you asking, but if it doesn't, please feel free to ask those questions of your practitioner. What is ethical behaviour support? It follows the clinical process. It has to tick all those compliance boxes, and there is a requirement to develop a written plan. So under the NDIS funded model, we can't provide positive behaviour support under improved relationships without writing a plan. It's part of the legislation. So what that plan looks like is often dictated to by that legislation, but remembering that also comes from what we know works in the positive behaviour field. So there is a requirement to write a written plan. Ethical behaviour support, you should be billed for the time it takes, not if there's cutting and pasting. There are elements of cutting and pasting in behaviour support. So, for example, there are little blurbs under response strategies, for example. These strategies will address how to respond to behaviours as those kind of parts of the behaviour plan, we will cut and paste because it's a outline of what this part of the plan is. So we don't charge to retype that. And there may be other avenues that we might use some cutting and pasting, but your behaviour support plan needs to be person-centred. It needs to be about that person. And if you don't feel like it is about you or the person that you're supporting, then talk to your practitioner about that. Just a little word on billing. The price limits very clearly outline what can be claimed and what can't. The Behaviour Support Practitioners Organisation needs to be adhering to that. There will be claims for travel, kilometres, report writing, phone calls and non-face-to-face by all organisations, but there's no claiming for admin. So, you know, putting your information into the client management system, that shouldn't be charged for, but we do need to write the report. We do need to charge for travel and kilometres. We often get families asking, can we come to the clinic to reduce the travel costs? And I think that's a really valid question. The difficulty in positive behaviour support is the research is very, very clear that understanding the person and their behaviours of concern in the environment that they occur and working with them in their own environment will get much better outcomes. A lot more positive outcomes than coming into a clinical environment. So that's the difficulty in this funded model of positive behaviour support, is we know that all the evidence is very strong that if we come to you and we observe the behaviours in the environment, we support the person in their different environments, we're more likely to see changes in the behaviour because it's so based on the environment. Behaviour, you behave in the environment you're in. Whereas if you come to the clinic, it's starting to more develop into a more therapy type model. We can still get positive outcomes as a positive practitioner if you come to the clinic, but they're not going to be as strong, the evidence suggests, as if we come to you. There's a lot more report writing. I think I've already gone through that in positive behaviour support, and always ask questions if you've got any concerns or questions around it. Most of you probably know behaviour support is funded in improved relationships. it's always been called improved relationships. And I think this is part of the problem why we get people funded in this line when it's not really positive behaviour support that they need, because the planners see the term relationships. But it is very much positive behaviour support. There is a social skills line under there as well, but that again is very different. When we access that funding as an organisation and the practitioner, they must follow a long list of compliance and legal requirements. There are fines up to $250,000. So, for example, if you have a regulated restricted practice, from the moment we see you, we need to document that and upload it to the Commission. That's the Commission watching us as practitioners. If that goes up a day late, so if we take 31 days to upload that, we have 30 days, they can fine us $250,000. And they have done in the past for some organisations. Real Therapy Solutions has not been one of those, just to make that clear, but they do actually, it's not a bluff. Now, that is not of concern to participants or the people that support them. That is a concern to make sure that the providers are doing what they are required to do. That's what we're here for. That's what we signed up for as an organisation and as a practitioner. That is not a concern for families or for support workers or for participants. But I just put that there so you can have an understanding of there are things that we will need to do that unfortunately we can't choose not to. Otherwise, there's a massive risk to us. If you have restricted practices, and I won't go into what they are here, but I'm happy to answer questions if anyone needs me to later. We have no choice but to jump straight in and do a report straight away. A very brief report with certain aspects in it. We have 30 days to get that to the Commission. And again, we can be fined if we don't. The difficulty here and understanding is that reporting and use of that funds to write that report is so that the Commission can oversee what we are doing as practitioners and make sure that if someone has a restricted practice in place, the practitioner is providing quality, positive behaviour support to that person. So it is by no means a measure of what the carers, particularly in a family home, are doing in their family home. So one of the things that I like to talk to families about, because often these restrictive practices are occurring in the family home, and understandably so, and that is the parental right of the parent to put these strategies in place. For example, it might be a timeout strategy, taking someone to their room to calm down and leaving them in their room until they've calmed down. That would be considered a regulated restrictive practice, which we would need to notify the Commission about. But that is not about us telling the family they're doing the wrong thing. The family has every right to do what they need to do within legal, and that is within legal reams, to manage their child's behaviour and the safety of that. But our job is to work with them so they don't need to use that in the future. And that's where the restrictive practices come into play. And this is really difficult for families as well, because it does mean your practitioner comes in and uses some of your funding to write a report that for many families at that point is not what they particularly want. And it's up to your practitioner to explain that to the families and why we're doing it, and use the least of your funding that we can to get that work done and follow our obligations. So we've seen this outlined previously with the what is behaviour support process. Your practitioner, based on your funding, needs to identify what parts of this can be done, and if there isn't enough funding, what parts can't be done. The difficulty with that is the effectiveness of the process is all of this has to happen. So if we're choosing, because there is not enough funding, to not do some of this, it's going to impact the outcome and the quality of the supports that are achieved. So, for example, we often see this implement the plan doesn't happen because by the time we followed all of these requirements, there's not enough funding left. And that's also a misunderstanding by the people that provide the funding. We also get people that get way too much funding, by the way, and we don't need the funding to get this process done. The problem is this implementation part of the plan is the most important part. As long as we get a good assessment and it's done correctly, you can't do implementation without an assessment. But once you've got that, this is where that practical magic starts to happen, where we're supporting the person, we're trialing strategies, we're making change. So this is the part where we are coming out more regularly face to face with the person. And this is part of the problem, and it's not new to NDIS world. It was often a problem even in the old funded models, that once the plan was written, the focus was sort of dropped a little bit. And I think that's not beneficial for the participants and for their positive outcomes.